Welcome back, everyone. This is going to be a little different. Rather than one speaker, it's going to be a panel, two of whom of the panelists you've already met. Of course, Keith Smith in the middle is the CEO and managing partner of the Surgery Center of Oklahoma, which is a multi-specialty facility here in town, which, as I mentioned, will be touring at 4:30. If anyone wants to go, sign up out at the table. Jay Kempton, another a founding member of the Free Market Medical Association, along with Keith. He's the CEO and managing partner of the president and CEO of the Kempton Group, which is the TPA here in Oklahoma City. And then the other panelist you haven't met is Jim Melloway, who's a partner at the Holmes Organization, which is a brokerage and consulting firm in Tulsa with offices in Oklahoma, Texas, and Arkansas. And he's also the founder of TheZeroCard.com, which is a unique marketplace for transparent healthcare services. So I'm going to let you three gentlemen talk, and we'll start with you, Keith.
Okay. Good morning. Adam's a hard act to follow, but I'll try. Adam, thanks again for coming. As a physician sitting in the audience, I understood most of what Adam was talking about in all the alphabet soup. But the other physicians in the audience, I know your head was swimming, probably having heard it for the first time like I did when I heard some of that for the first time. When we put our prices online, our idea in the very beginning was to attract individuals, people with high deductibles, people that had no insurance at all. And like I've said, the Canadians were the first ones that showed up. I said, somebody recently, the millions of Canadians streaming across the border to get care in this country have discovered the only single payer upon which they can rely is themselves. But we had a little bit of success, but it was very slow, and I remember being very frustrated that it didn't take off a little more. And we were actually self-funded, and we're self-funded at the Surgery Center of Oklahoma. We have, I think, 39 employees, and we're self-funded, and we've saved about $3.5 million in 8 years net. So I'm saying all this because for those physicians out there who don't know these things, 60% of all claims paid that are not paid by the government are paid by self-funded companies. And these are wages that otherwise would have been paid to these employees. So it's just one step away from a direct payment from that patient, really. It is such a gigantic market that to not tap that, to not try to plug in and get involved with the self-funded entities is really foolhardy. And the ability to really change healthcare in the United States, I think, and use the power and the beauty of the market is dependent on tapping into that market. It is so huge that the price deflation that will result, it is resulting right here in Oklahoma City right now, that forces all of the players to scratch their head and take a look at all of the prices for everyone. So, Adam Smith, he brokered the argument between David Hume and Francis Hutcheson. In Scotland, they used to have these arguments in the pubs, and Francis Hutcheson was a devoutly Christian man who believed ultimately man would do the right thing for his neighbor. And David Hume was an atheistic skeptic, brilliant guy. But he believed man would always do what was in his self-interest. And these two men were great friends, and they had these lively debates in Edinburgh and Glasgow, and just had these wonderful debates attended by, you couldn't get in the place when you read the descriptions. And this fellow named Adam Smith shows up, and he ends the debate series by pointing out that they were both right, that when we act in our self-interest, everyone else's boat floats higher. When the physicians understand a lot or even a little bit of the terminology that you hear coming from the brokers and the self-funded benefit administrators, when you understand that and you figure out how to tap into that market and to understand that and to help the employers understand that you are willing to embrace the discipline of the market, just like they do in their business. That you will see is in your self-interest, but you will also see that all of the players that are receiving health care in the entire country will benefit. All ships will float higher just from the mutually beneficial interaction. Corey Cook, her advice to me when we first met was to identify and avoid the layers. And that rings in my head a lot because as a physician, I have a hard time, I'm not trained that way. I mean, I'm not trained to identify layers that don't belong. And a lot of people that are in the healthcare business are layers and frankly are evil. These two guys are not part of that. Jim Milloway is a broker who is earning his living the ethical way, the right way. And Jim, his idea is to save his clients money. His idea is to introduce and accelerate, to pour gas on the free market model of healthcare delivery. And he's anxious to have more players like me and like everybody in this room. I mean, the more the better. I mean, you want me to have competitors, I think.
Oh, yeah. Yeah, certainly.
Well, as Adam had mentioned, most employers out there, whether they be fully insured or self-funded, they trust the advice of their broker or their agent. As Corey said yesterday, as Keith just said, to avoid the layers. Corey Cook yesterday said, if you're going to do business with anybody as an employer with your employee benefit plan, you want to always seek value. Seek value with the provider. Seek value with your benefits administrator, like a TPA like us, but then also with the broker that you choose. There needs to be somebody that is truly working in your self-interest and is helping to foster the ability to seek value in other areas. And Jim Millway at the Holmes Organization, Bobby Bramlett is another broker that's here present, and also Colin McNeese. Those are three individuals that, as Keith just said, they get paid the right way by bringing value, and they were invited to come here to talk about how, because and you guys, I've told you all this before, and y'all won't, I don't think, will be offended, but TPAs are good at selling steak. These guys are good at selling sizzle. But what's going to make this movement grow with employers to provide the demand side for you all are going to be folks like some of these right-minded brokers. So Jim has been doing some pretty cool things in this space, as Keith said, to throw some fuel on the fire. So Jim, you want to talk about what you're doing?
Yeah, I'll tell you guys a quick story, and I told Keith this story for the first time last night, and in the spirit of transparency, we'll use everybody's real name.
We like naming names.
There's a manufacturer outside of Chicago, Illinois, in a suburb called Rockford, Illinois, called Bergstrom, Inc. And unless you're in the trucking business, you have no idea who Bergstrom is. But if you were in the trucking business, they more than likely built the AC unit in every truck cab you have. And they've got 700 employees or so in Rockford, Illinois, and they called us and said, hey, we heard about what's going on in Oklahoma City, and we want that kind of deal for us. I said, we don't have any providers in Rockford. They said, well, we don't care. We'll fly everybody to Oklahoma City. So we said, okay. And then we didn't tell them, because it really only took us not too long to find some providers when we said, hey, do you want some cash-paying customers that pay in 5 days? And the provider said, yeah, sure. But here's what happened. The title of this talk was How the Market Works, or How It Doesn't Work, depending on what your perspective is. And so we go up there and we see them, we meet with their brokers and all this, and we say, okay, here's what we need. We know that you guys buy into this, but we need claims data. We want to show you really how much you've been overpaying. Even though we don't need it for you guys to hire us, we think we owe it to you to show it. So we go to Blue Cross, or their broker does, who's their ASO, and we say, hey, we need the claims data. And then Blue Cross says,
To see what they've been paying out of their own corporate assets.
so Blue Cross says, well, what do they want the claims data for? And I said, just tell them we're doing an analysis. The broker says, great news. I got the claims data, but I need you to sign something. So he emails me this, and I'll read you this. I'd never seen this, so this is new. This is exciting. And I told the broker, I said, did you read this thing? And he said, well, I kind of skimmed over it. And I said, I hope you didn't sign it because I'm going to read you one thing. Company, that would be Holmes, expressly agrees to refrain from utilizing the confidential information for the purpose of providing transparency services. Transparency services means services provided by company, me, to mutual client Bergstrom, through which mutual client, get this, may receive information about out-of-pocket estimates for future health care services, cost and/or quality of providers. Essentially saying, sign your soul away and we'll give you the data. Now, the good thing is these large carriers, they don't pay a whole lot of attention to a lot of other things, and it turned out they'd given the broker claims level access, so we were able to just extract it.
Oops.
The broker said, great news, I was able to back into it. But here's what they were protecting. We looked at a population with Kempton's help of less than 700 employees in Rockford, Illinois. And we said, we want to see all the things that we would consider elective, or that would fall into a corridor where if an employee had an option and an easy resource to get to the fair price doc, how much could you save? We found $4 million in billed charges in about an 18-month period. And Blue Cross was successfully able to negotiate those charges down to $1.7 million. Hey, that's $2.3 million in savings. That's how people buy and sell in the network world. Well, when we looked at those 18 months, that $1.7 million, when we compare them to fair free market prices, it was $660 grand. You can imagine the reaction of an employer of less than 1,000 people when the CFO just realized he paid a premium to leave $1 million on the table. That's what employers are fighting. And you have to do everything you can to find people like Keith, and if you can't, then just get people to Keith. Because in my world, and brokers, so, we're like the most bribed people on earth. I can't tell you how many people come to my office and say, look, we're going to save these people $500,000, but we'll give you 25% of the cut. So there's always...
Second only to TPAs.
So whether it's wellness, disease management, all these vendors that are just siphoning off of your folks, and they want you to believe, and they want employers to believe, that the reason why healthcare is out of control, because everybody in this room drinks too much, and they're too fat, and they smoke too much, and they don't exercise, and they can't make good decisions, and they're just bad shoppers, it's made up. An article I would encourage everybody to Google, and the nice thing about it is you don't have to read it. The abstract will give you the point in the first page, too. In 2013, the Journal of the American Medical Association released an article called Anatomy of Healthcare in the United States. And they asked pretty much one question. What happened since 2000? How did everything what happened to the cost? And they said that since 2000, cost, especially of health systems, administrative devices and drugs, drove 91% of cost increases, price and price alone. So you could have been doing everything on earth correct, but an MRI went from $200 to $400 to $800 to $4,000. And, that's what you have to get. And Adam makes a good point. Nobody asks. Nobody has any idea what any of these things cost.
Everybody's quick to believe when you're told, well, that's just what it costs. Healthcare is expensive, and most employers, most patients just say, well, there's people that are watching this for me. And so, when Keith, one of the very first for the reason video is when you made your statement that healthcare really doesn't cost that much. I think the first time a lot of us in this business heard that line, your jaw just kind of hits the floor, because that's counter to everything that we've always been told. So anyway, it's good stuff. We kind of envisioned this being kind of a Q&A as well, so we didn't really have any prepared remarks, as you all know us. But yeah, go ahead.
What do you guys What do you see as an appropriate level of compensation to incentivize a broker to push this methodology out to their employer groups?
Okay, so I think unequivocally, you can't let your broker take commissions on anything. I mean, not a single thing. It has to be a straight fee. And if you want to look at it like you pay an attorney and how much time your broker's really spending on it, I mean, you can look at it like that, but you know, you meet and talk, and generally if our fee's about half what they're paying their other broker, but you know, we do some on per employee per month basis. They're priced like that because people want to see them. We have other employers that pay us flat fees. You know, we have employers with 15,000 employees, and people say, "Oh my God, that must be the best account. How rich are those guys getting?" Well, they pay us $100,000 a year. We see brokers with fully insured accounts with 200 employees making $200,000 a year. I mean, the fact is, people don't know what they're paying their brokers either. And I mean, you pay them like you pay any kind of service provider, and make sure you're getting value out of them. Keep in mind, all these things that happened in Bergstrom and Rockford, Illinois, the reason why the other broker went and had to figure out a way to extract that data is because the broker said to me in an email, "We can't push back on Blue Cross anymore because we need them." I mean, that's a pretty clear signal that you're not getting a whole lot of value out of them.
I had a question about if you've had any success at basically negotiating deals with hospitals, and just wanted to share some of my personal experience. I negotiate directly with providers to get discount prices and contract with them directly for my patients that have no health insurance. I sit on the board of trustees of my hospital, so I sat down and had a meeting with our chief financial officer, and I said, if I get a phone call in the middle of the night and my patient tells me they're having chest pain and I tell them to go to the emergency room, what financial commitment have I just made to that patient by giving them that advice? Because I want to have a ballpark as to what they're going to be expected to pay. Is it $1,000? Is it $10,000? And the short answer was, well, we need more specifics, so we really can't give you that information. And I said, well, that's your most common visit to your emergency room is chest pain, so you should have some idea of what you're going to bill for that sort of thing. And we even got down to the point where I said, okay, patient comes in, they get a chest x-ray, they get an EKG, you give them an aspirin, they get morphine, they have a turkey sandwich, and they're there for 8 hours. What's the bill going to be? And there's absolutely, we couldn't get there from there. And then it went further to the point of if I said, if we could get the patient to pay you, basically give you a credit card right then, what sort of breaks can we get on that? And they said, well, there is no real mechanism. Even if we wanted to do that, there's no way for us to do that on the front end. We'd have to completely redesign our systems to make that happen.
You asked a couple questions there. The one, about, certain areas within medicine that, we can't come up with a price. We have no mechanism to take cash. What I found in this adventure is that where there's a will, there's a way. In other words, if the provider under their own free will wants to operate their practice or their facility in this manner, they can figure it out. We've seen that over and over. But as far as negotiating with a hospital, like Adam had mentioned, a lot of the hospitals, if they're not willing to talk and interact, you're kind of stuck with network contracts. He said that it was kind of a hybrid is kind of the approach that makes some sense, and that's kind of what we believe in too. But there are a couple of areas that I think most good TPAs will kind of draw the line saying one of them is dialysis treatment. Other thing that kind of got my man crush on Keith going was over implantable devices. Implantable devices are something that we've had a lot of fist fights with hospitals because, like I said in my opening remarks, we require an implant invoice for every single implantable for every single client of ours. And if we don't, and by the way, we hold at our company, we hold implant charges to whatever the hospital paid for the implant plus 100%. That's our allowable. I don't care whether it's a network or not network. That's just a limited benefit written into the plan. And I see some of y'all licking your chops going, wow, if I can make 100% on every, you'd like that.
Yep.
Except that it's
Crazy.
It's not ethical. But some of the hospitals that we'll get into some fistfights for, you would have thought that we just stole their firstborn.
Baylor.
You got it. I mean, they will drive, they will sue a TPA, an employer, anybody that stands in their way, even when you're offering something that is incredibly it's reasonable, it's rational and everything else, but as Adam said, they don't care. The agreement said X, you did Y, hang on, you're hearing from our attorney.
Yeah, and Lee, and something else to understand is because they won't give you an answer, doesn't mean they can't. They don't want to. I mean, it's game over for them if they do. I got a call. One thing I'm doing, we're not just providing prices online for our facility. Some facilities here in town, their lawyers have told them they can't post prices because it might conflict with some federal contract that they have. We don't take any federal money, so I don't care. But there are hospitals in town that take federal money, and they've been told they can't post prices. So I post their prices on our website. And he posts their prices, and you guys probably do. So, but Deaconess Hospital is it's a huge thing. They've come to the table, and I get prices out of them every day. And one of the things I'm doing to try to demonstrate value to our new kind of partners that are paying us for their employees' health care is to broker arrangements that are not at our facility. They're procedures that are just not appropriately done on an outpatient basis. And so I get a call, like I did last week. Guy had a laparoscopic band for his obesity, and the band was too tight. And so he had a gastric inlet obstruction, basically, and he had to have this band taken off. Well, this is a big incision on your abdomen about this long, and they resect part of your intestines and reconnect it to the stomach. I mean, this is a real surgery, big deal. Somebody's in the hospital probably 7 days for this. And what are we going to do? This is hard on our plan. This could be a big deal. This is an employer benefit administrator I'm talking with. And I said, well, let me check. So this is rocket science. I call general surgeon. How much do you want for a gastrojejunostomy? Yeah, well, how long are they going to be in the hospital? Well, probably 7 days. How about X? Oh, that's a lot more than I get paid by Blue Cross. Are you good? Good. Anesthesia group. This case is going to take probably 2 hours and 15 minutes. How much do you want? Ah, well, we did this a couple weeks ago with you. I think this is a good amount. Done. Hospital, email, their CFO, gastrojejunostomy, likely 6-day hospital stay. Within an hour, I get an answer. $6,750, including 4 days, with $500 a day stay after that, period. It doesn't matter if they're in the ICU. It doesn't matter what drugs they got, what IV fluids. It doesn't matter how long they were in the recovery room. $6,750 plus $500 a day after day 4, because 4 days were included in that. And that good news is delivered. And you know what? Nobody had a gun in their mouth that was giving me those prices. They're all making money. So when somebody says we can't do that, or they can, I mean, it's happening. I mean, we're doing it here every day.
And there's not a huge incentive for a lot of them. I mean, they're making a lot of money. I mean, an easy way to figure out who's got cash in town is just see who has a crane in their parking lot.
In their ER.
Yeah. And it'll give you a real idea. But, in every big health system you talk to, and Jay hears this, and I'm sure everybody, we hear the same thing. Well, you don't understand. We've got uncompensated care. We've got all these, we got an ICU, we got a burn unit, we have all these things. But the reality of the situation is that's not my problem. It's not my problem. There's inefficiencies, and it's not an employer's problem. There's inefficiencies in that model. And I always think about what Jeff Bezos from Amazon said when he said, we unequivocally will never ask our customers to pay for inefficiencies. But we all still do. And until we stop, it's not going to happen. You see it in California when CalPERS and those big places, throw UCLA Medical Center out of the network, and suddenly, I like to think that free markets help Catholic hospitals find religion. I mean, suddenly they want to play. But But you got to get people moving, and you got to get people walking out of the doors and making decisions. And you know, and you got to make it simple for people to do that. And that's when at lunch, Dr. Schwartz and I'll tell you how we think we make it simple. But I mean, you just got to make it happen.
The nun who runs the Catholic Hospital Association makes $925,000 a year. Just speaking to that.
That are some of those cost issues that they have.
Hey,
That-
and I'm Catholic, so I can say that.
You know, what Jim said, though, about the Amazon quote, I mean, we hear it all the time when we talk to hospitals or even other ambulatory surgery centers. I mean, we hear it off and on all over. And that's, well, you just don't understand, you know, we can't give you a good deal because we have all these cost issues. And my gosh, have you seen our facility? It's amazing. It's in this really great part of town. And you know, I've gotten some strange looks because I'll face to face or over the phone, I'll just show them, you know, I don't care. You know, the seller's cost problems are rarely ever the buyer's problem. I mean, when I hear somebody say, well, you know, we have to charge $4,000 for an MRI here because of giving me all these reasons. So, well, you know, you've actually made a pretty compelling case that you're a really great place not to buy an MRI from. And they're not used to hearing that, but those are the market discipline that, you know, if you've done things within your facility that requires you to have to charge $4,000 for a shoulder MRI, you probably need to look at your investments because I'm, you know, an informed buyer's not going to pay that. The fact is, though, they're not used to seeing informed buyers.
Question about how this all integrates or how direct pay can maybe insinuate itself into this. I mean, I believe personally, and I think a lot of direct pay physicians believe that the economic or the costs of medicine are wrapped up in the economic perversions of the billing cycle. In other words, the CPT codes support the premiums justify the CPT codes, and around and around we go. And one of our mantras in direct pay is kill the claim. So, you know, that we shouldn't have to file a claim, you know, from, you know, hangnails to heart attacks. I mean, there's certain things that, you know, can be just paid for. How, with the way membership models work with direct primary care or, you know, cash-only a la carte services or however you structure your payment, how do we get that, how do we get direct primary care, you know, into these self-funded plans?
That's a good question. Where that's ongoing. In fact, your table mate right next to you works for me, and this is something that's a topic of our conversations ongoing. I mean, we've been talking about that in some of our meetings that we've had here in Oklahoma City with some of the providers, the free market providers, some of the, like Jeffrey Davenport and his team, we've been talking about that. I think there is definitely, there's a will, and so I think that there would be a way. One of the big issues for an employer group, a self-funded employer group, is again, unless the employer is in one location and your practice happens to be right there close to them, that's pretty easy. But if you're talking about multiple locations and you've got an employee base that, you know, they're not going to move not every single person is going to come to your practice and be your doc. Maybe they need 3 or 4 or 8 or 10, you know, direct primary care physicians. Administratively, it kind of becomes burdensome for an employer or a benefits administrator to deal with those multiple layers. Now, we would never want to get you back into the claim business because we don't like primary care claims either. So we want to look at a way to make it very, very efficient. But somehow being able to aggregate those membership fees and then be able to come up with some methodology where, say, an employer could maybe pay half of it or some portion of it to some sort of an entity, and then each direct primary care doc kind of gets paid, and you kind of manage, you know, when y'all are dealing with individual patients, I mean, you all kind of manage eligibility. I don't want to use an insurance term here, but you manage eligibility, you know, who's paid and who's not paid. If you start having an aggregator, now you kind of start getting into eligibility questions. You know, is everybody paid? Does Sally Sue still work for that employer? Are they still getting? But we're very cognizant that we don't want to drag those direct primary. We're trying to hammer out some sort of a deal where we don't get back into the complexities of the status quo, but it's ongoing.
And how exciting is it that, I mean, Lee Gross is here with Epiphany Health, and Atlas MD was here yesterday, and he's in the same room with these guys and these guys. And so that's how it happens, is that you get these elements together that typically don't interact. And I mean, Lee's concept is extremely out of the box and entrepreneurial, and Atlas MD is too. And like, there's a will, there's a way. I think that the solution is there, and when it's landed on some night, suddenly when Lee wakes up in the middle of the night, that it'll be, duh, that was easy. And it'd be like, putting prices online, duh. But that's one, I just wanted to say that, because that's kind of thing we had in mind for this association and this group, was to get the minds together that can make these decisions. And somebody's got an idea, and the person that's going to implement it says, no, that won't work because of this. And then you find out how to do it. I think it's doable.
Yeah, we're trying to build a new marketplace here. So yeah, I'm trying to connect these islands of innovation. Was what was kind of the thought. So.
Good morning. Keith, in your opening statements, you said ID and avoid the layers that don't belong. And I think probably there's a significant number of people that don't even know the layers. So if you guys could kind of go through and say, here's what the layers are, and then be able to identify what those are that you say to avoid.
I confess to not being great at identifying them, so I'm going to defer to these guys. Seriously.
So here's the easiest way to cheat on doing it. So probably some of the direct primary care guys know Garrison Bliss at Q Lions. So if you Google Garrison Bliss workflow, he took a great workflow that said, here's how primary care works outside of direct primary care, and here's how it doesn't. And it gives you an idea of all the touch points. And a lot of those touch points are going to be similar, whether that's primary care or whether it's a knee replacement. And it'll differ in health systems, and it'll differ slightly from parts of the country. But Dr. Bliss's workflow gives you a real easy way to kind of cheat at it and say, because I promise you there's 10 things that are never going to cross your mind that came into that. And, you know, you just have to, I mean, you can look at those type of things, and I think it's different, so it's hard to say for what you're looking at. You can look at that. You can probably Google and find some Virginia Mason value streams for like their lower back program and see how someone like Virginia Mason, who is a health system, really kind of gets it. So there's some people out there that'll give you kind of a template that you can work off of to try to figure out who's just fat in the equation. So every employer, including every single person in here, over the last 10 years, wages have stayed relatively the same, but compensation has gotten huge because it's all on that benefits piece. So you just got to figure out who's dipping their toe in that and start cutting them out.
From my perspective, you know, the biggest layer that you know, or the PPOs. I mean, I said it from the very beginning, but I mean, you know, Adam just gets, you know, the TPAs in the room just gets our blood boiling because he articulates some of the frustration that we're dealing with. But yeah, for the providers, you know, getting the managed care companies out of the way, getting the preferred provider organizations out of the way. We like preferred providers. We don't like the organization part. You know, that's what we're looking for, are providers that we can deal with more closely. But that's a big layer. You know, brokers that get paid on a percent of claims or a percent of premium, that's a layer. TPAs, if you're a self-funded employer or you're dealing with self-funded employers, if they're dealing with a third-party administrator that somehow gets paid on a percentage of the claims savings that they provide. I mean, that you know, that starts to dull the incentives. You know, the incentives are not in the right place anymore. As Adam said, you know, if you're out there making money off of the percent of some sort of savings generated, how do you maximize that revenue? You know, the pitch to the employer is, well, you want me incentive when I save you more money. Well, how do we save you more money? By having a larger bill to start with. So those are some of the layers. I don't know if that answered your question completely, but, okay.
Yeah, so we had a TPA that one of our employers negotiated an out-of-network facility with an out-of-network doc and anesthesiologist for a spinal fusion, but they saved us $90,000. They spent $120,000 of the plan's money without asking and made it in-network for the employee, so there was zero skin in the game. And then when the CFO about ripped their face off, they said, oh, well, tell us what number we should call and ask. And I said, what? And they said, well, if it's over 50,000, should we call? And I said, no, tell people to use common sense. Because if you're paying 15 grand for an MRI, it's below the threshold, but still a horrible deal. I mean, they just don't get it, you know? I mean, I can't tell you how many times on that call we heard that we saved $90,000. And for that surgery, Stan, what'd that surgeon get paid? You remember?
82,000.
For what?
It was a internal fixation of the scoliosis.
But we saved 90 grand. That's fat in the system.
Keep saying that.
I'll tell you one thing I learned that, and I still hear things that my mouth just falls open. When my wife and I went to the Caymans, gave a speech down there to a captive group, this Berkeley group, and there was a former broker for a huge brokerage. It was Gallagher, and he had a crisis of conscience and confessed to me that when they looked at their clients and they were trying to decide which carrier, which PPO to recommend to a General Electric or whoever, they had a spreadsheet and they had all the decision points. And the last one, the most prominent one, were overrides. So if Aetna felt like they really, really, really had to have this account, they paid that broker more to recommend Aetna to that client. So there's a layer. I mean, that's the kind of stuff that's behind the veil that, these doctors that here, you're probably crossing your eyes. I mean, we don't even think about that kind of stuff, but that's the kind of dirty stuff that's going on, and why it's important for the clinicians in the room to interact directly with those who are actually paying these bills. And those are the layers mess it all up.
Yeah, Todd.
That's come up a couple of times, the communication. This is not a normal conversation because we're just starting it. You've obviously been there, the two of you. Do you have some suggestions for us on, how do we go about doing that? The communications directly between the providers and the facilitators.
Well, you and I are having that conversation. I mean, Dan, you and I are having that conversation. Jay and I are with. I think that as there is more and more interest, and there will be more interest because more patients are walking out of facilities and physicians' offices because they're not part of this. They're not part of this deal, and so we've got everybody's attention. There's more and more physicians want to be part of this and understand the benefits of, by and large, not even dealing with the carriers. They're going to be eager to have that conversation more and more. This association, I think, can facilitate that. We've actually kind of been playing with a local affiliate of this association where those conversations are happening. So I could see that, or even regionally having those conversations. And all the physicians that I talk to, they want to know, how do I plug into this? How can I be like you in the primary care world? How running Oklahoma Spine Hospital, how can we do that? Oklahoma Heart Hospital. I think Deaconess Hospital eventually is going to just give us a list of prices, and I won't have to ask for them. I think that's close.
And there's like a handful of people in the country that sit on the broker or consulting side or kind of in that realm that really get it. I mean, so like if someone said, we had a discussion last night about Clearwater, Florida, and they said, as a facility, what's our next step? And I said, oh, hey, I think we know some guys that have clinics in Clearwater, Florida. I mean, as long as people are open and talking, it's pretty easy to get to them. I mean, you look at just the people in this room, like an Adam Russo or a Jay or somebody that knows Keith. I mean, it's pretty easy to get the buyers and the sellers together when you just open yourself up to the dialogue of it.
And it's also better for me to not have that conversation. I have those conversations now because I kind of get the lingo. But for a noob, it's probably not a good idea to have that conversation directly with an employer because they're going to ask things and use letters and you're not going to know. It's better for these guys to, and for Adam and Corey to go out and swing an axe. And so, here's a deal you need to know about employer because like Jim says, I mean, it's the employers are listening to and traditionally don't trust the unethical idiot who charges $82,000 for scoliosis repair. I mean, how do you trust that guy ever again? So,
And it's tough.
he shouldn't be having that. That guy is not, he doesn't have any credibility. These guys should be having those conversations, I think, on our behalf, by and large.
If you can find brokers or consultants that understand it and say, hey, we think you can make a lot of money by effectively sizzling us up, like Jay says. I mean, the brokers that get it will do it. But yeah, you got to get in because every employer is different. It's like every other thing. It's like some places, like the last person on earth you need to talk to is the person running the benefits plan. And other places
Yeah.
it absolutely is. Other places you have to be at the CFO. Other places the CFO's a dope. I mean,
Well,
so,
and Todd, that's that's on the employer side, but on the facility side, it was what you were asking. We found the last person you want to talk to about transparency is the director of managed care. They don't get it. I mean, all they know is what the last Blue Cross rep told them. And so you've got to get to that facility manager. You've got to get to the CFO or the CEO of that facility. You've got to have somebody that you can get your hands on. And then the other thing that we do, and this is actually kind of a principle of the FMMA, and we don't have really a list of principles yet, but I'm going to vote to have this be on there, would be that any time an employer on their own or through their third-party administrator or wherever, if a facility was to come up with bundled cash pricing, then we're going to get a button that says one cash price for all. And that, what I mean by that, that's a pretty powerful statement if you understand what I'm saying, and that is, this business, kind of how we got to where we are with all the distortions and all the layers, is these PPO networks are essentially, they are pricing brokers. You buy access through them to get a price, not a good price, just a price. So there's an entire industry of layer that is out there hawking discounts. And again, this is not about dictating to anybody what they can charge. The free market will determine whether your price is good or not. But what we do ask, and this is Keith's model, and that is, he didn't care whether it was Sally Sue uninsured walking down the sidewalk, or if it was Blue Cross and Blue Shield, or if it was Kempton Group or Health Smart or whoever. If you want access to my pricing, it's good. But you better make this, it's got to be a cash transaction or something that's equivalent to cash type of transaction. If you can pay me fast and 100-cent dollars, then that pricing is good. But we have had some facilities that have looked at this and said, well, we want to be transparent and have cash pricing for you. Oh, but we're going to have different cash pricing for somebody else. That's a slippery slope. We know what that looks like. That looks like today. And so that would just be that's something else that we always carry out there to the provider when we're talking about this, is there's an industry of self-funded employers out there that want to deal with you. But if you don't want to get in the business of if you don't like networks and you don't like all the distortion, then you're going to need to come up with a one cash price for all. And if somebody don't want to pay you cash and they want to make it subject to deductible or whatever, we can definitely have that conversation. But we think that the price should vary depending on whether it's cash or it's something less than cash.
Just from a primary care perspective, as a physician, just doing this for a few months, I've started learning a lot, and one of my favorite questions is, well, how does that person get paid? because that tells me what their motivation is. And I'm asking the employers because I don't know. I'm like, well, how do you pay that person? And when I find out stuff like, well, they're paid on commission and things like this, I start asking the question is like, so do they have any incentive to change or give you a better deal as an employer if there is one out there? And so I'm trying, just from my own perspective, to put a bug into some employers' ears and make them think, okay, well, they don't have an incentive to change, so they're an added layer. That causes expense. And even some of the employers, I try to talk to them and I try to suggest some of the members in this room, and they look at me funny because they don't want to think about it, and that's very frustrating. But I just keep trying to ask the question, well, what incentive is there for the people you're working with now to do better for you?
Well, and Jeff, some of this is happening over kind of the dead bodies of some of these brokerage houses. Express Personnel Services came to us directly after Steve Lantier had a meeting with him at a dinner party or a party, I think, and they got real interested, and their director of HR saw the wisdom of it, and, you know, you start talking like a free marketer, and we had their attention because that's who they are, and, you know, their broker just sat there just like this the whole time we were having this meeting, and they want no part of it, and Express just steamrolled them. So they not only don't have an incentive to change, they have every reason not to. So some of these deals, that's what's so exciting, is that the ice is being broken around these people that have otherwise, and up until now, have been impenetrable.
And they're conflicted. So a big broker is really internally conflicted. I mean, you look at a Willis, you look at a Marsh, or a Mercer or a Lockton, like, really? I mean, they're going to go cut the revenue at 40% of their clients? I mean, they're doing business with all the big guys. I mean, that's who those guys unequivocally use. I mean, and nobody at Willis is saying, you know, we really got to figure out a way to pound us, to pound HCA. I mean, that's not happening.
Saying earlier about, like in Deaconess, they were having a concern about putting their prices online because of regulations. What other blocks and regulations do you see that will come up, maybe for the bigger hospitals, on trying to implement this?
Well, the current concern, and the concern that all the in-the-box lawyers have, you know, if you want to get something done in healthcare legally, don't hire a healthcare lawyer for the most part, I'd say. They just can't think outside of the box. But one concern is that advertising a price that's less than a federal contract that's currently in place is an issue. There also, I think, have been issues raised about advertising prices that are less than PPO contracts. And that's a problem too. I think some of the hospitals are worried about.
Based on contracts they've previously signed.
Yes. So, you know, our goal is to be third-party free. And when we're darn near there. I mean, I think we have 3 contracts left. I mean, we're canceling them as fast as we can. One of the most delicious conversations I've ever had was about 3 months ago when an unethical outfit had absconded with our name here locally. And they were throwing us up on their website as being affiliated with us. And I said, well, how the hell are they doing this? So I found out that we had an old PPO contract that I'd forgotten about. I mean, we had it like in 1999, and I didn't even know we had it. Well, they were renting access to us through that network that I had completely forgotten about.
They were renting a rental network.
Renting a rental network to get to us, to throw our name up, to show their clients that, hey, we've got Surgery Center Club at our network. Well, no, they don't either. Well, I called the rental network and said, you're fired. They said, you can't do that. I mean, it's total panic. It was awesome. To hear the PPO people on the other end of the phone, they were in a complete panic.
Because they were making a big deal about how they have this free market warriors in their network and everything. So this was
I was telling them they're fired. Yeah, you're doing business with this outfit, which is a huge outfit, and I'm not doing business with them, and I didn't even realize they were coming in this back door. They're fired. And they said, well, will you stay with us if we fire that big outfit? And I said, for the time being. I mean, it was too good. I couldn't say no. But again, again, to post prices that differ with some of those contracts, I think is an issue for some, but we're trying to be completely contract ridden. I mean, we don't want any contracts so that we can just, and again, I mean, I don't really care. I mean, if a payer right now with whom I had a contract came to me and said, you know, we're going to kick you out of the network because you're posting your prices, I mean, Steve and I would go have drinks. I mean, we're that much closer. And frankly, if they kicked us out, that would be a real problem for an employer who is gaining access to us through that network, because now what option does he have? He can only directly contract. But the obstacles to post prices are primarily federal. They're primarily federal contracts, some network contracts, but primarily federal.
Thank you so much for putting this forum together. I feel so grateful to be here over the last couple days and to listen to all of the ideas. My question relates to the numerator in the value equation, which is primarily quality in terms of outcomes. And it's very interesting because my question is your experience around the hunger or desire or courage that it takes to be transparent around that numerator and how it relates to how the market would move. And I ask that primarily because it seems appealing for a provider, no matter what kind of quality of care they deliver, to move into this space. But what are the methods that people are using to assess whether good care is delivered, not just in the surgical realm or procedures, but longer term care, et cetera? And what are those conversations?
That sounds like a Dr. Jaffrey question.
And I'll talk to it in general. Quality's hard. Steve Lante's pointed out many times that if you look at a facility where the surgeons are doing unnecessary surgery and their patients are doing real well, it's because there was nothing wrong with them to start with. So how do you know? A friend of mine who's in the PR business told me recently that the hospitals would attack me ultimately on quality, and I needed to go out and buy an award. You know, you see the Malcolm Baldrige Award. Well, they buy that. Or I think it was Jeff Rice yesterday said there's 700 hospitals on the best 100 hospitals list. So quality's hard. It can be gamed. It can be gamed in the outpatient surgery business. It's infection rates. It's deaths. It's unanticipated hospital admissions. And further, you could say, well, this is how many of these procedures that we do. And after that, I think it is uninterpretable. Marty Macri, whose economics are trash, wrote a book about transparency and quality, and he threw up his hands at the end of the book. He's a pancreatic surgeon from Hopkins. He threw up his hands at the end of the book and said, you know, what we came up with was a survey where we threw it out to all of the employees of a hospital and said, would you have your surgery here? And that was the most reliable indicator of quality. And my dad asked me yesterday, he said, well, why don't you just ask the patient who just walked out of the facility, how'd it go? And word of mouth is the quality that any other business goes by. So I don't know, my answer is very general, but I look at measurements of quality with a real jaundiced eye because I think at some point they're gamed. Here's the other thing. I think one of the reasons there's a real push federally for quality measurement is that is the infrastructure for rationing. When a patient walks in and they have diabetes and coronary artery disease and chronic obstructive pulmonary disease and they need a whatever procedure, their outcome is likely not going to look as quality as the person who comes in who's perfectly healthy. If the pay for performance or that sort of insanity really comes about, that person just gets in line. And the doctor who thinks he's going to be rated or marked because that quality outcome doesn't look good, it's like Doug said yesterday, what if I've got a diabetic that likes to eat cake? Quality will build, focus on quality measurement, I believe, is very exciting for the feds, because that builds the infrastructure for rationing, because they don't want those really sick people to get care, because it costs a lot of money, and that's one way to balance the budget when you have people that are wards of the state.
Hey, Keith, speak about, real quickly, the power of ideas, and specifically, I'm thinking about our relationship with Oklahoma County and the inertia that's building.
Yeah, we, and many of y'all may not know, but Jay is the one that threw gas on us and finally put us on the map, because that was our plug into the self-funded world. And then we were approached by Dan Oliver and John Wilkerson and Tom Bartlett. I don't know if Tom's still here, and Todd Archer. And they had these clients, one of the largest of which was Oklahoma County. So Oklahoma County is the biggest county in the state of Oklahoma, and they have 1,800 employees or more, and plus dependent belly buttons. So will you extend, your cash pricing to us for this? And well, sure. Interestingly, this is a government entity. I'm sorry. I mean, we're taking government money now. So
Still spends though, right?
yeah, but it's the sanction. Interestingly, it's the sanction of the Oklahoma County alliance with us. It's the sanction of the government that has brought this huge surge in the credibility of what we're doing here, which I think is fascinating. And that may be what you're getting to, Steve. Yeah, and it has caused a huge interest. I mean, my office in the afternoons is like a situation room, and I type pretty fast. But responding to the requests from individual patients, from Tracy Krieger, from you guys, I mean, just the requests that come over for surgery, but the requests that come over from employers and TPAs, even in a larger it's just the inertia seemed to be overcome with the addition of our new partners, HealthSmart, and it's very, very exciting.
We have time for one more question, and fittingly, it's from Dr. Orient.
Keith, I wish you'd say a little bit more about unnecessary surgery and quality. Tom Emmerich, who was formerly an executive at Walmart, has written this book, Cracking Healthcare Costs, is really, really negative about physicians. And he claims that when they looked into like spine surgery, they found that maybe half of the patients were having surgery unnecessarily. And I'm not sure how he judged that except by sending them for a second opinion at a facility that he trusted. How can we get a grip on that?
Well, and the reason that's happening, and I think the number of unnecessary spine surgeries is very high. Maybe one of the most unethical parts of the practice of medicine is pain management, and that's just a cesspool where all kinds of unnecessary stuff's going on. That's probably the worst one. Although the guy in Michigan giving chemotherapy to people who don't have cancer is did you all read about that? He was going to buy a 3 million pound castle in London, and that was their first clue that something was wrong. But yeah, I think a very high percentage of the spine surgeries are unnecessary. And again, it's because the buyer is not the receiver of the care. I mean, it's the market. It's the lack of pricing. If you look somebody in the eye and you say, as a physician, I'm going to charge you $82,000 for the scoliosis repair on your 13-year-old daughter, those people are going to walk out. But they probably didn't feel that sticker shock in the beginning, and that's part of the problem with spine surgery and some of these other things. You can get an aortic valve replacement here in Oklahoma City now, cash, for $32,000 from top guys whose quality looks like Cleveland Clinic or better. $32,000, is that about right?
Yep.
$32,000 cash right here, and that's 1 year's premiums insurance in Massachusetts now. So it's price. I mean, it's price transparency. It's, hey, we'll we're going to charge whatever we want and we're going to get it for spine surgery, then a whole lot of spine surgeries are going to be done that are not necessary. I think that's what it boils down to, Jane.
And I might also interject, Dr. Orient, when I told you all my introductory remarks, I kind of shook Keith's hand and said, hey, we're going to start paying this at 100%, not really knowing how to do it. And as I'm driving back to the office after we had our meeting, the beginning of all this, the other thing that popped into my mind that I think, oh my gosh, have I just stepped in it? Because I felt like I was breaking the cardinal rule of benefits administration and insurance. And that is, I have just made an expensive benefit free to the buyer. And that we're not supposed to do that, right, guys? I mean, overutilization is, we have just set the perfect storm up for overutilization. So the pricing was great, but the concern of overutilization was definitely there. We've actually have had some requests for that kind of information, and one of the things, it's kind of easy for us to look at a procedure that has been recommended but has not been done. Most of the procedures that end up coming to Dr. Smith or any of the other providers that are doing this, which, like I said, there's quite a few, but those are usually they're referrals from a primary care physician, and usually that's somebody that's not affiliated with this movement, unfortunately. We're going to work on that though, right, Jeff? But it's coming from that, and so they've already been told, yeah, you need to have surgery, and I'm going to send you over here to the hospital. And then that employee said, no, time out. I have this benefit at work, and if I have it done at some of these other places, then I might be able to get it for free. So it's almost like a self-redirection. And then when they go to, for instance, Keith's facility, part of our arrangement is that there's a pre-surgical consult that happens. And that pre-surgical consult, the surgeon gets paid $200 for that. And it's essentially it's a pre-surgical consult, but if the doc ended up saying, the surgeon says, I don't really think you need this now. I think, a little PT and an injection might take care of this. Then from our perspective, from the third-party administrator's perspective, we simply see a $200 consult. So, even somebody like us with, I got an Okie State education, I'm able to look at that data and say, don't need an algorithm. I can just see the number of consults that I have versus the number of actual surgeries that I have, and I can come up with essentially how well are these providers like Dr. Smith and others, how well are they kind of self-policing, or are they just every time they see somebody they cut on them? And we just looked at that, and after 4 years of this, we're at about 16% consults, which, as I understand, is a pretty large number.
And 30% for orthopedics.
Yeah.
Which
16 overall.
So even in a world where it's free, and even in our world at Holmes, where not only is it free, we got rid of, every person that we have in these models, we got rid of utilization review. There's no pre-certification. There's no prior authorization. The thing's wide open, and they're not abusing it. Not only are they not abusing it, 30% for orthopedic surgeries. And Tom Emmerich will tell you, I don't care how good of a price you get on a knee, if a third of them didn't need to happen, and we're seeing the market correct itself.
And we attribute that, at least from our perspective, we attribute that to the relationship. It's like what we're hopefully forging here with you all, that you don't see these self-insured employers as Blue Cross or Aetna or anything else. You see it as your neighbor, that manufacturer down the street that employs 300 folks. And Keith, you've mentioned also that this is good business.
Oh, it's the best business. I call a surgeon, he answers on the first ring, because I'm paying 3-4 times what he gets paid by some of these carriers. And y'all see them now. Sit them down. We got 2 guys who said we're going to close our office and sit in the pre-op area, and you just go, hey, and we'll see them right there. Tell them to come now, because it's the best business they have. And it is self-policing, because Steve and I value our relationship with HealthSmart and EPS and you guys, and And we do, but you know what? Because it's such great business for the surgeons, they don't want to mess it up. And Steve and I wouldn't have to do anything. If any of our staff thought that a surgeon was an inappropriate utilizer, the other surgeons would murder him because nobody wants to mess this up. And if you plug into this, you'll get a taste of it and you'll see.
Well, let's thank our panelists.